So the patient is a 70-year-old male with a Barrett esophagus since 2018, C10M11, without dysplasia 2 years ago. On follow-up, there was a focal low-grade dysplasia without visible lesions 2 months ago. On the next slide, you can see some pictures of last endoscopy.
So we just introduced the endoscope in this patient's esophagus. Important point to start with, this patient is under general anesthesia, not only because of the sake for the fact that we are now in a workshop, but in fact, I would advise you to do every Barrett's esophagus under deep sedation or preferentially under general anesthesia. That's always the way that we do it, because you need to take your time to have a very good look, to take the biopsies, etc. So I think that's crucial to have a very good prepared patient. Another point is that Hannes already told you this is a patient with low-grade dysplasia. When you have a referral or when you see a report of the pathologist saying low-grade dysplasia, always read the details of the pathology report. And then in a majority of cases, you will find in the description that there is a lot of inflammation, that there are inflammatory cells, and that of course means that it is possible that it's not real dysplasia. Does this patient still have reflux symptoms? Does he take adequate dose of PPIs? So I remember when I saw this patient a couple of months ago that in fact he was having now and then some heartburn. So what I did is 2 months ago, I doubled his dose of PPI. So he has been taking 2 times 40 milligrams of pantoprazole or omeprazole until today. He's asymptomatic now. And so now we are going to do the control for this long segment Barrett. So.
Professor Bishops, I have a question. Do you think there is a role for artificial intelligence in this setting?
Yeah, I mean, I've been collaborating, so been participating in a consortium in Holland, and they've done some nice work. It's still in its infancy, so it's now it was validated now, was presented at the Dutch Society, and probably they have an abstract also at UEG this week coming up, where they take pictures, and these pictures can then be analyzed on site with the computer and indicating whether it's normal or not. But like the real live detection, that is still preliminary. There's some other good data from Germany, from Helmut Messmann's group, from Augsburg, that do it on videos, but still the numbers of videos that were included for training are quite limited. So we're talking about around 20 or 25 of these patients. So there's still a lot of work to be done. Like I said, this is not really the low-hanging fruit. This is more the high-end and challenging part of AI and endoscopy, I think. And it will take some more time, but things are moving forward, and I think in the end we will get there. And we will get some indications of where to take biopsies during surveillance, but I think this will take a couple of years longer before we are there. If you want to make a souffle, you don't want it to insufflate, you want it to sufflate, right? And then you need to follow the right recipe. And let's have a look at the recipe of the Euro 2 trial, which had excellent results. You can see that before the patient entered this trial with high success, cancer was an exclusion criteria on 2 subsequent high-resolution endoscopies with the Seattle protocol. So if one biopsy showed cancer, the patient was out. So no cancer was ablated in that study. And that is the recipe for success. And so you certainly should talk to the patient, right? So that's a very good point. You should definitely address the side effects. In the time when we were conducting the SURF trial, we actually included one patient with a C0M2. And after one treatment, he developed one of the most severe strictures I've ever experienced. So it's not because they didn't have an EMR or ESD that this cannot happen. So you can have side effects for something that's probably in that case was a very low risk, right? So you need to discuss this. From a practical point, an ethical point of view, we take charge of the patients that have multiplicity of low-grade dysplasia, so that means at different levels on multiple or at least 2 or 3 endoscopies that has been confirmed, and also taking comorbidity in advance. in consideration. So if I have a 45-year-old patient with me with a long segment Barrett's and multifocal confirmed low-grade dysplasia, well, the hospital pays for that at this stage. For shorter segment Barrett's, we have alternatives at this stage with hybrid APC, I think. But to do a 10 centimeter Barrett's with hybrid APC is feasible. They did it in the hybrid APC trial in Germany, but technically it's much more demanding than doing it with RFA. So yeah, it's a bit of an ethical issue, and we're working on that right now. Hopefully we will get it, but it's hard to put it in a good definition because we also do not want to overtreat patients that may not need it.
With this, I would like to conclude the session. I would like to thank everyone that participated, and especially Raf for his excellent talk and expertise. Thank you.